Welcome, and thank you for joining us for today's HIS Talk webinar, How Presbyterian Healthcare Services is Preparing for a Post-Pandemic Future Using Digital Care Tools. It's brought to you by Vitamd. I'm Lori from HIS Talk, and I'll be moderating. We have two speakers today. First, we have Ray Costantini, MD, who is the CEO and co-founder of Vitamd. Dr. Costantini is a pioneering healthcare executive, innovative physician, and seasoned entrepreneur who is passionate about making healthcare better. Prior to founding Vitamd, he led the design, build, deployment, and operations of 3 groundbreaking telehealth and digital health products at Providence Health and Services, one of the largest health systems in the country. He also previously founded 3 successful companies and is a national speaker on healthcare innovation, telehealth, and patient engagement. Joining Dr. Costantini will be Reese Robinson, MD, who is the Chief Information Officer at Presbyterian Healthcare Services. Dr. Robinson's current focus is helping Presbyterian identify, pilot, adopt, and scale innovation for the benefits of patients and members. Within this global umbrella, Dr. Robinson has focused on patient access issues with the goal of reducing the burden on providers and empowering patients to better manage their health conditions. With that, I'll turn it over to you, Ray.
Thank you so much. Appreciate it. And Reese, really a pleasure to talk with you. Always enjoy our conversations and looking forward to that with you today. I think it probably makes sense for me to start with just a quick overview around what it is that Vitamd does so that there's a little bit of context, and then jump into the conversation. I think that's probably the most engaging part of what we're looking for today. So the quick version for folks who aren't familiar, Vitamd is a company that is really focused on what we call care automation, which is about helping to streamline the process of delivering care, making it more efficient and high value for all settings of care, and in particular, remote care. So if you think about what Vitamd does as being, the best analogy is probably a virtual medical resident. We use a set of technologies, conversational AI, EHR integrations, to be able to make software that reviews the EMR system, interviews the patient, writes up chart notes, has a set of contextually relevant and situationally specific orders and prescriptions and referrals that help support the care delivery process for those clinicians, and makes it so that care delivery, instead of taking 18 to 22 minutes of provider time per visit, brings that down to about 2 minutes of total provider time per visit, with patient satisfaction scores that are in the mid to high 90s, provider satisfaction scores also in those same ranges, adherence to evidence-based best practices that are 2 times what you see in video-based settings, and quite a bit of improved access and cost of care that comes from that efficiency as well. So with that as a foundation, Reese, really looking forward to talking with you more about what your experience has been. It's been a crazy 8 months. I would say the last 8 months has probably seen more change in healthcare than we've probably seen in the 8 years before that. I suspect that you guys are probably feeling that at least as much as we are, probably quite a bit more. In fact, the healthcare delivery systems are really on the sharp end of the spear of COVID. Tell me a little bit, how did Presbyterian prepare is not really the right word. How did Presbyterian navigate COVID-19? What kind of tools did you have in place already? What did you need to do in response to the craziness that we've all been navigating? Tell us a little bit more about that.
Well, first, we had a Vitamd in place as an asynchronous tool at Presbyterian. I think in calendar year 2019, we did about 30,000 visits, a lot. So it was a very well understood tool, a very liked tool. So if you roll back to March, COVID begins to hit, and I think all of us are scared. I would say I was. And what we did as an organization, we said, okay, we're going to have those individuals that may have COVID. They may be coming into our urgent cares or to our emergency rooms. They might be infecting people that are compromised, chronic conditioned individuals. How do we get ahead of this? So what we elected to do is, working with our state, we agreed to open up for free to any person an asynchronous visit, so that we were minimizing the traffic of people into our clinics specific with COVID symptoms. So we created a website, we created an automated registration tool, and they could come in and take a smart exam. And in the initial days of COVID, we didn't have enough tests. So what we wanted to do was to evaluate those individuals that we felt really had COVID, and we wanted to test and possibly see in person. So in those early days, it was kind of remarkable. We had a testing facility that we opened, and it had these long lines of cars. And what we actually did, we put a scan code on the billboards in the line. They could scan it with their phone. We would automatically register them, and they would take a COVID test. And every once in a while, you'd see a car turn around. And I stopped a couple when I was out there, and I said, did you just get frustrated? He said, no, my fears have been allayed. I took a smart exam. I received feedback from the provider, and I feel comfortable that the symptoms I have aren't COVID related. So what we saw was almost a factor of 4 or 5 increase during March and April, where people were not wanting to go see urgent care, but feeling very, very comfortable with the Vitamd system.
I love that tie of what I call clicks and bricks, Reese. And I think, being able to take that digital experience and connect it to what would have been a bricks and mortar experience, I think is a really thoughtful way of applying technology. It's, I think, to me, increasingly, it's not about telehealth versus in-person care. It's about how do we use digital tools to be able to make that process better. And I think that's a great example of the innovation that you brought to Presbyterian. You bring up another interesting point, folks who aren't able to get care. In-person visits became a lot more complicated, to say the least, during COVID. And patients and providers have embraced these digital care tools more, sometimes by just force of environment. But through that process, one of the things that I've heard from a lot of health systems, from providers, from patients, is that this digital divide has also become more obvious. There's less in-person options, and so by having digital options being often the only option available to patients, that's really expanded that chasm that we have between those who can and can't easily access care digitally. Presbyterian and New Mexico is kind of in a unique situation around that, where that may be even more obvious. How have you addressed that?
The digital divide is a huge issue. And you think about this, you'd say, okay, within that frame of providing care, you'd have a phone, and then you have asynchronous, there'd be video and in-person. And you're right, there's kind of an overwhelming, video is the solution mandate or thought process. The reality is we've experienced really big difficulties on being able to create an effective connection with our patients. So those of you, New Mexico, I think it's one of the great places to live. But the reality is it's a poor state. About half the population lives in Albuquerque, and then the rest of it is economically challenged, let's say. So we have looked through this. When we now interact with our patients, one of the first things we have to do is assess whether they have the bandwidth capabilities, and many don't. So when you think about Smart Exam, it doesn't require 40 megabits per second. which is kind of a level that you need for a good video call, it can be much, much less. And many of these people don't have the packages where they can engage in a 20-minute video visit. So it's been the preferred tool. So when we have people come into our system and they're offered both a video visit and an asynchronous visit, they select the asynchronous visit 3 or 4 to 1. It's a very pronounced selection bias to use the asynchronous modality.
How's that been received by clinicians? I mean, I think there's a question that comes up in people's minds of, do I need to be using video in order to deliver high quality care? Is that something that you guys have run into?
No, I would say that is not something we've run into, because, and it's important, because we had a significant experience of working with Vitamd really over several years. The comfort with the quality of care that we could deliver through Vitamd was very high. And let me just talk about this, if you will, kind of the trust issue. And what I mean by that is we've worked a lot with our clinicians, and I remember one of them, this was early on, saying, well, I trust it. I trust it. And I thought, that's interesting. She said, no. She said, I can have an MA or other individual take a symptom and a history, and if it's late on Friday or it's right before lunch, they may do it in one way, another person may do it another. What I appreciate is the consistency and thoroughness of the information captured from Vitamd. So as we rolled into this, people were aware of that. Really, I mean, you guys, I always tease you, you ask too many questions, but I mean, it's a very thorough examination that provides the information that physicians need. So our physician community was very, very comfortable with that. And remember, in this crisis, you have, increased needs of care, and you're looking for efficiency. So a video visit by design isn't, at least for us, it's no more efficient than an in-person visit. And due to some of the technical problems, our video visits have actually taken longer. So you're losing ground in that efficiency arena. So to the extent that we can deliver high quality care through an asynchronous visit in less time, I mean, I'm not a rocket science, but you can figure that out. That's exactly the direction you want to go.
Yeah. I think that's something interesting. I really appreciate all of the focus that COVID has brought on the patient as a healthcare consumer and the need for health systems to be meeting patients where they're at. I think that increased focus is really powerful. I do think you bring up something interesting, which is in that process, something that we haven't put as much focus on as an industry is giving clinicians the tools that they need in order to change the way, improve the way that they're able to deliver that care. And it has been, I would say, a harrowing time for clinicians. And we started out this whole thing back in January. We were still 15% short on clinician capacity relative to patient demand nationally. I know even the spikes that of utilization we've seen are difficult to even measure the level of capacity and need mismatch that we've had. One, how have your clinicians been holding up around this? And two, how are you seeing that play out over time? I mean, I can't imagine that we're going to see less clinician attrition and more supply-demand mismatch and more provider burnout post-COVID than we did pre-COVID. How are you navigating that?
Well, I think they're kind of, it's a supply-demand issue, and let's talk about the current and then what I think is the future. So as it stands today, we've tried to move back to in-person visits, but because of the continuing, our kids are not in school in New Mexico, So we have a number of providers who have kids that are home. So they're not able to really return to the clinic. But doing a video visit with a 2 or a 3 or a 4-year-old child is very challenging. So those providers, if you see them on a Friday, they are fried, because that's a very difficult challenge. So we've really been trying to work with those providers to say, let's try to increase our asynchronous video or asynchronous visits. How do we begin to do those? Because that stress of trying to do a video visit or do an in-person visit when you have any child less than 6, that's difficult. And what you're doing is those people are emotionally, they're fried. I also think you just got to look at this and say at the other end, so that's a younger group of providers. At the other end, some of our more senior providers are really just, I think, wondering what is the practice of medicine for them the next several years. So what that does is it says to me as the Chief Innovation Officer, what we need to do is we need to be extraordinarily efficient in the care we provide. And the best tool that we have for doing that is asynchronous visits. So let's continue to promote it. How do we gather both the information for an asynchronous visit, but also on a telehealth visit? How do we gather information? So we're working with you right now to implement tools that gather clinically relevant information near in time to improve the efficiency of in-person visits, video visits, or telephone visits. So, if you ever talk to me, I'm all about how do we take our most precious resource, which is our providers, and allow them to do what they're uniquely qualified to do. And being IT support or gathering med information or other things like that, they didn't go to medical school and residency to document that information.
Yeah, that's an area.
Yeah.
No, I'm laughing because I agree. I mean, honestly, it's an interesting thing. I've really come to realize that we have created a process where our clinicians work for the computers. And my personal goal is to flip that around and put those tools out there where we put the clinician back in charge, put them at the top of their license, give them the tools that they need so that the computer is working for them instead of the other way around. So I'm only laughing because it's not because I disagree, it's because I agree really deeply. And Reese, the other thing, just tying back to where we started the conversation, I mean, it's not, in my mind, it's not about telehealth versus in-person care. It is about how do we take digital tools and transform not just where we can get and give care from, but how are we doing that? So I love where you're pointed with this, and we're excited to be working with you on taking care automation and applying it in other settings. We've spent so much of the last 8 months just in the now, navigating through the tempest that has been COVID. I think it's good for us to reflect forward a little bit also, which can be difficult in the middle of navigating a crisis. But, as we're looking forward, into the hopefully relatively near future in the spectrum of things where COVID is less of an acute issue and something that we have hopefully gotten our arms as a nation and as a planet wrapped around. What do you see care delivery looking like in, I'll be optimistic and say 9 months, or less optimistic and say 12 to 18 months, hopefully on the nearer side of that. But what do you see care delivery looking like in that kind of a time frame as we're moving forward?
Well, I think it's still going to come down to, you use the care automation or care efficiency. And I think you will see a provider group that emerges from the COVID pandemic, probably mentally, emotionally, and physically fractured. So within that framework, you may say, well, what do we as a system need to do to help those providers? And I think one of the things we talk a lot about is elasticity in the way in which they can deliver care. So if you think about that, it'd say, okay, it might be they're able to do it at home, or they're able to do it, maybe even while they're walking on a smartphone or a tablet or other modalities of that way. So I really think we're looking at saying, how do we take that group of physicians that have been through a difficult period and create elasticity in how they deliver care, how they do it efficiently? And it's something that people talk about. How do we return the joy of medicine back to them? Because I would say if you talk to the average physician today, they're not using joy in their current environment. It's a difficult environment. So we're trying to really look at that very proactively. And as I mentioned, that's asynchronous care. It's gathering pre-visit information effectively and packaging it. It's creating a variety of care modalities, both for the patients and the providers. We're doing some work on trying to teleport the physician, maybe even to the patient's home. So we've got a lot of activities present that really are trying to look at, how do we return the joy to medicine at a provider level, at a system level? How do we do it effectively? And at a patient level, how do we meet the patient where they need care? Instead of saying you've got to fit in care venue A or B, can we create A, B, C, D, and E, and really meet the patient at the appropriate venue?
You had talked about, I love that concept of elasticity in care. I'm stealing that from you, by the way, just so you know. I definitely, that's going into my collection. But you talked about that also in the context of impact on scheduling. Was another way I think I've heard you talk about this in the past, and I always thought that was a fascinating thing. And I know you and I have talked about this, and I think this is something that the audience is likely to get some value out of as well. How do you see that playing out more?
Well, you have it's a fundamental mismatch because, a physician is scheduled with standard time increments. But we know that the practice of care is not in standard increments. So if you're a provider and your first visit of the day takes twice as much time as it's scheduled for, what happens is your stress level goes up because every person afterwards is going to be delayed by that amount, and they're mad at you.
I remember.
I wouldn't wish that on anybody.
No.
So what you have is, you can just imagine if we all said we're only allowed to spend 1 minute looking at email. Well, that'd be too much for some and too little for others. But asynchronous care allows that flexibility. And I think that's really a critical element as we look at, meeting the needs of providers, but also the needs of patients. Because a patient in the SmartMD system, they complete the information, and then they're free to do whatever they want to do. Take care of their kid, they can eat, they can take a shower, and they can come back to it. They're not tethered to, I've got to be online, and I'm not tethered sitting in a clinic where I'm worried about getting COVID, or I'm not sitting in my car where it's cold or hot, depending upon the time of year. So that care or timing elasticity is something we're really thinking a lot about, and especially at the provider level, because I can imagine we started this a little bit late. Your stress level went up, right? It had to. So you kind of go, okay, well, let's not do that to our providers every single day.
Yeah, and that's something I've heard from a lot of folks is that in fact the impact of that scheduling on a digital experience, a video experience, in some ways has even been magnified. I mean, once you've taken the time as a patient to drive into the clinic, you might be frustrated, but you're also pot committed to the process. How have you seen that playing out on the digital front?
Well, that's a big issue. I mean, we get hammered in our customer feedback as it relates to that. The problem's not simple. So if you're in a waiting room you can see people coming in and out, and you know you're in the correct location. And I guess you could go ask the nurse or the person at registration. So there's a mechanism. If you're in a waiting room or waiting for a video visit, you're there. Does anybody talk to you? Do you see any interaction? Are you in the right location? Do you have your speaker on? So what we're seeing is a great deal of stress. And it's not a simple problem because providers don't say, I'm starting the visit, I'm 15% through, I'm 25% through, I'm 30% through. They're almost like a great white shark. They only surface infrequently and allow their position to be known. So it's really a very difficult thing to solve at the expectation of patients. So if you think about patients, they probably think this video activity should run like a plane taking off, you know, but a plane sends out a ping and you know exactly where it is. Providers aren't that way. So it's a difficult challenge to address. And I kind of go, well, is there a simpler way to do it? And it's making it asynchronous.
Yeah. I think, you know, in the business world, we end up thinking a lot about barriers to entry. I mean, in some ways, this context, it's barriers to exit for the patient in a digital landscape have actually become lower. You know, you're sitting in a digital waiting room, and the barrier to them leaving that process, if they're frustrated, confused, unsure, that's a much lower barrier than where it used to be when you were in the waiting room. You could talk with somebody, you could understand, you could get reassurance. I think I'm hearing a lot of that. That to me plays into this broader change that I think that we're seeing in healthcare that I think has accelerated with the pandemic also, which is this change in the market landscape. I mean, even more pointedly, the competitive landscape of healthcare delivery. Tell me, I mean, this has got to be a non-trivial part of what you're thinking about in leading the strategy and innovation work that's happening at Presbyterian. How are you thinking about that? How do you talk with other health systems about it? How do you talk about it internally at Presbyterian?
Well, I think it starts with an appreciation that the standard inpatient doctor's visit is one of the least differentiated products in the world. You have very healthy people, you have chronically ill, all coming in. And I think one of the things we're really trying to do is to say, how do we satisfy our patient and member needs? And that's by creating products that meet their needs, not what we want to provide. And I think that's really a mindset that we're continuing to really work on is what are those venues? How are they represented? And importantly, how do you help people get to the right venue? So, you know, if you got on presbyterian.phs.org today, you'd see we have a Get Care Today, and it's a navigation system that says when
Great
you
function.
do it, if you have a sore throat, what's the recommended venue of care? You'd see right there it's an asynchronous visit. So what we're really trying to do is, one, create the products that meet the patient needs, and then also create the tools that allow the patients to sort through what is a fairly complex product offering, at least at Presbyterian.
Yeah. One of the things that I think plays into the same arena is the changing set of folks that are there and offering care to patients. I think you're right that to me, this idea, this increasing acknowledgement that patients are healthcare consumers. They're a special type of consumer, and we have to acknowledge that, and we have to be thinking about that relationship and the importance of it. There's a whole set of folks out there that have recognized that. I mean, there are a lot of new entrant competitors in the healthcare delivery system space. When I was at Providence, you know, I would venture to say that the folks that we thought about as competitors were the bricks and mortar health systems inside of our geography. How are you seeing that evolve? Who do you, even if you're not going to name names, you know, how do you think about that landscape at this point?
Well, I think you're right. There's a lot of new entrants that are coming in, and I think, we look at big retail being one of those that has an opportunity to be quite successful. But, we're a not-for-profit healthcare system with a mission to take care of the people of New Mexico. And if we do that well, I think we will maintain their trust. Trust is also an important element behind that. So I was very proud of us as a healthcare system opening up and saying, we're going to take care of and test anyone that has COVID symptoms. And we're going to do those type of things. So I think it really comes down to saying, the basis upon which they will look to compete is in part the convenience and digital integration, where they may have better tools. And what we've got to do is be responsive to the needs of our patients.
Yeah, I don't disagree with you. I think the interesting thing that that I see playing out more and more is in increasing awareness of traditional healthcare delivery systems, that if they're not willing to come back full circle to where I think we started the interview and where you were talking about, if we don't acknowledge the fact that patients are healthcare consumers and that there are entities out there who will meet them where they're at and where they want to be, they have a broader set of choices out there, and those barriers to change are lower and lower for those patients. To put a not so blunt point on that, I mean, direct to consumer telehealth is more than happy to be able to pull patients away from traditional healthcare delivery systems. Walmart has made it their stated strategic goal to be the largest primary care provider in the world. My guess is that Amazon Care is looking at what Teladoc is doing, and I imagine there's some salivation somewhere up in Seattle about the opportunity that they could have to be able to engage patients directly. I'm sure that those are things that you guys are thinking about. To me, this comes back to that same point that you were making also. One of the opportunities that traditional healthcare delivery systems have that may not have been as well played out in the past, but I think there's an opportunity around opportunity always comes from something that's not working as well as it should. And in a lot of ways, I think healthcare delivery systems have given their patients historically, they've been forced into almost a false choice. Do I want convenience and fixed price and digital access, or do I want the trusted relationship and comprehensive care that can come from a traditional health system? And they've had to pick between those two. And I hear a lot of what you guys are doing is really removing that choice, giving patients both of those things, saying we're going to give you that digital first, consumer friendly experience, and tying that to the trusted relationship and the value that comes from a compassionate not-for-profit health system looking to meet the needs of New Mexico. I love that myself. I think it's become one of the, I will call it a silver lining that seems to have come out of COVID, is that I think remote care has become increasingly almost table stakes. Health systems that don't offer remote care are now, in some ways, it's not a unique offering. It's if you don't have it, you're behind. What do you as a strategic, thoughtful innovator, you're talking with other health systems. What do you say to health systems that have implemented video-based telehealth and feel like they've checked the box for digital care, that they're in good shape at this point?
Well, I mean, I think you can check the box, but the devil is really in the implementation of the new care modalities you're looking to introduce. So I think if you use a sort of off-the-shelf remote set of providers that are delivering your telehealth venue, and it's done through a platform that seems foreign to people, that's not a very good experience. And what you really want to try to do is to create a real continuum experience for those individuals. And it really starts with, as they enter your website, and we don't do it perfectly, but as you enter the website, you want to create a handheld digital experience to the extent you can. And it's the little things that matter. It's really, it's the experience you create, the confidence they have, the efficiency with which it transpires. You're not creating new passwords, new logins. So I really look at it and say, if the only thing you're doing is a off-the-shelf purchased video platform, you're probably behind, because I think you've got to look at those other care modalities, again, to meet people where their needs are transpiring.
Yeah. I'm just monitoring our time. You and I can talk. I love talking with you, Reese. So I'm going to remind folks also, we're looking for questions. So if there are questions out there from folks, make sure you get those in, and we'll be coming into those in just a few minutes. And with that reminder, let me check with you. I think you guys have been really progressive. I think Presbyterian has a strong reputation that comes from the work that you guys have done in leading that shift from fee-for-service into value-based care. I think in some ways it's interesting in that, we've almost made those dichotomous to each other. Are you fee-for-service or are you value-based care? I would venture to say that that's probably not an accurate reflection of the 95+% of healthcare delivery systems in the country. Almost everyone is a blend of those, and it's a question of what ratio is it, and what direction are you going. I think one of the interesting questions out there is how do these kinds of care modalities, these digital transformation tools, the care automation, how do you see that playing not only in a value-based care setting, how do you see that playing out in a fee-for-service world? You guys certainly do both. How do you see that?
Well, the reality is it causes complexity in the billing that you can provide for any sort of alternative care venue. And we are, in many ways, from an innovation and adoption perspective, advantaged at Presbyterian because the majority of care is capitated. So in New Mexico, Medicaid is capitated. We have a large insurance plan, and we have an MA plan. So when you look at it, if you can provide the same quality of care more efficiently from a provider perspective and more effectively from a patient perspective, not sitting in a waiting room, you've created that win-win. So that's in the framework of value-based care. One of the things that did transpire here in New Mexico is we have fee parity. So at least for now, the ability to bill a comparable code for different modalities of care, it's not perfect, but we are being paid for the care delivered. So that allows us now to look at it and say, okay, these modalities are not, we're giving away care for free, but we can actually invoice for it. So you're right, it's a difficult balance. I hope it becomes such that, the compensation is driven by the process of the quality of care and the overall benefit to the patient. And I think it's going the right direction.
I do too. I think that train has left the station. The question is, how fast is it moving? And it's arguably moving faster in some markets than in others. I do a lot of talking with a lot of health systems across the country. I can't remember the last time that somebody said fee-for-service is the future of healthcare. It's been a long time since I've heard that. It's still an interesting thing to be navigating that. And to me, I think that's part of the beauty of where you were talking about earlier about care automation being applicable across venues. With purely asynchronous, there's an opportunity to be able to make these 2-minute visits apiece. But if you got parity reimbursement for a video, you can make it so that instead of doing 3 of those an hour, you can do 10. And instead of having that MA note as you're walking into the exam room in an in-person setting, having that virtual medical residence note there, so that you're coming in knowledgeable and equipped. You've got a better platform for the conversations that you want to be having with your patient. You can, to your point, you can bring some humanity back to healthcare for the patient and for the provider, and make those a lot more efficient as well. That's to me, I know, I see that as also being a real opportunity, both for fee-for-service and for value-based care. It's that question of how do you use that capacity that you've created. So, well, let me pause, because I do think, same thing, we need to have coffee more often, because I love talking with you, Reese. It is always a pleasure. I want to make sure that we make room for questions that have come up from other folks in the audience. Lori, anything that we should be addressing that's come in?
Yeah, thanks, Ray. I just want to let the audience know that we have a lot of questions and we have 10 minutes. So if we are unable to get to your question within this time, somebody from Vitamd will be happy to get back to you individually. The first question, Deborah would like you to please describe exactly what an asynchronous visit using Vitamd looks like.
Reese, you want me to take a pass at that? And then I think, being on the sharp end of the spear and being the user of it at Presbyterian, I think it would be great for you to fill in anything that you feel like I had missed around that. But I will try and keep this compact, and certainly something we're happy to follow up with folks around. I think, to be honest, I think a demo really speaks volumes. It's hard to fully convey exactly what a virtual medical resident looks like without seeing it. But the quick version, you think about from a purely asynchronous standpoint, that patient logs in through the Presbyterian website, that virtual medical resident, that through a single sign-on, they click a button and launch into that Vitamd platform, fully branded and white labeled. That virtual medical resident goes to work, goes into the EMR system instantly and pulls out demographic information, insurance information, meds, allergies, problem list, visit history. And that all fuels a conversational AI interview with the patient. So actually asking the patient questions, adapting to their specific circumstances and symptoms, diving deep on areas where there is more clinical need, pulling back in areas where it doesn't make sense to ask those questions. So truly an interview, not an intake form. And then all that information then gets packaged up and translated from a fourth grade patient-friendly interview into a chart-ready medicalese SOAP note there for the clinician. So we've done all the documentation all the way down to the thinking part of the note, the assessment and plan. We put that in front of the clinician and then empower them to exercise their clinical judgment. So make changes to the suggested diagnosis. We've created a differential diagnosis and a set of evidence-based treatment recommendations to go along with that chart note. But then the clinician is fully empowered to be making those changes. And in fact, we're supporting them with that elbow side clinical decision support. Patient has allergies, we're going to adjust those recommendations. Patient preferences are for their child to have suspensions instead of capsules. We make those adjustments inside of there. So instead of having to spend 100 clicks in an EMR, it's 4 or 5 clicks inside of Vitamd. And then based on that clinician's judgment, all of that reflects in the chart note, in a set of personalized patient education materials, billing files, all of that gets taken care of, put back into the EMR system as structured data, sent to the pharmacy for fulfillment on the prescription side, or put forward in terms of referrals or other downstream connections. And it's really taking the clinician out of content creation and putting them into the role of diagnosis, treatment, content review, where they can be really closer to their top of licensed practice. And patients are getting care nationally. I won't talk about Presbyterian specific numbers, but nationally it's about 6.5 minutes of patient wait time between their finishing their interview and the time that they've received care. So hopefully that paints a good picture. And Reese, fill in anything that you feel like I've missed on that one from your standpoint.
Good job. I didn't have anything to add.
Appreciate that.
Okay, I think this one is for Reese. Sage and Catherine both have questions about the implementation process, what it was like from a time frame and adoption perspective, and also what has been the best aspect of BrightMD.
You know, there's a lot of tools where the lift is, I'd say, overwhelming. But the way that BrightMD connects with your system is there's a process by which you navigate a patient to the BrightMD system. Your providers can then easily access the information content created. There are good tools for issues that come up, and then the information can be moved back into your electronic medical record. So the overall implementation, I wouldn't say it's a walk in the park, but it's been one of the easier things we've done. The second part of that question was, what was it? I forgot.
I think they were asking you what's the best part of working with BrightMD.
Oh, it's talking to Ray. No, you know, the thing that
right.
I would say, our patients like it. You know, our NPS scores are very, very high, and our providers like it. And anytime, you know, as the Chief Innovation Officer, you end up in a position where the providers like the tool and the patients like the tool, you're in a win-win. And one of the interesting things on this is we have smart exam shifts. So we don't overlay it on you're at the clinic and then you got to do smart exam. We just have individuals that do it. When those shifts become available, they fill up within about 2 to 5 minutes. That just says the providers really like this care modality. It's not for all of them, but there are some that enjoy the elasticity. They like the process, and I think that's been, you know, when you think about that for just say, you say we'll do about 50,000 visits this year. So you kind of go, that's a lot of visits. That's a lot of check-in, check-out, drive, sit, move, and we're doing that whole process, you know, very, very efficiently, and that makes me happy. I'd say that's the best thing. One is it's the efficiency with which we do it, the quality by which it is done, and the volume. That's just a lot of visits.
Yeah, and Lori, just to put, I'm going to give the unexciting but very tangible answer to the first piece of that, so that folks have a sense of it. A typical implementation timeline with all of those bidirectional structured data integrations. You know, we've got FHIR, we've got HL7. Typically, about 12 weeks is the timeline for implementation. We've seen those go live as quick as about 60 days from contract signing to go live. I spent enough time on the health system side of things that we really pushed the BrightMD team to make sure that we're working to make those integrations and implementations as light a lift as possible. It's part of how we work with our health systems. So, and Reese, I think I owe you a bottle of scotch for that nice compliment. I'm glad to hear that it's at least close to as much fun for you to be talking with me as it is for me to be talking with you. So, Lori, I've got lots of questions, but are there for Reese? But are there other ones that, given the time that we've got, I'd rather make sure we're answering audience questions than me diving in.
We do have several other questions. Reese, do you have time for one or two more?
Sure.
Okay, Paul would like to know how Presbyterian is protecting the PHI for patients as it's moving from the asynchronous video, and he says there's a lot of data coordination, and what is the source of truth as seen by the provider at that point of care?
You know, you may be able to do that better, Ray. I know that we went through the whole security review, and that's all satisfied everything. The exact mechanisms, I don't know.
That's fair. We are very robust in our security processes. So let me answer those questions in the reverse order. We always think of the EHR system as that source of truth, the same way that a human resident would. You know, we go into the EHR system, we pull that information out, we use that to be able to interview the patient, to inform the clinician who's making those decisions, and then we put it back into the EHR system as that system of record. So not looking to be the EMR system by any means. We are the interface that streamlines the clinician's workflow and supplements that workflow to make their job easier. And security, without going deep on that conversation, we are fully SOC 2 compliant. We spend a lot of time making sure that all of our connectivity and data management is pristine. It's something that, again, we think of that as being even more foundational than table stakes for having health system customers. We know how important that is, and we've been scrubbed by some of the most opinionated healthcare delivery systems in the country, Presbyterian certainly being one of those in terms of our security processes. So certainly happy to go deeper on the specifics in that, and it's something we do with every single customer as we're working with them. So.
Okay, respecting the timeline, I'm going to stop there, and thank you for joining us for today, attendees. Ray and Reese, it was an interesting and engaging presentation, which I really enjoyed. Attendees, please watch your email for links to the recording of today's webinar, as well as the PDF version of the PowerPoint presentation. We'll also include a link to the most recent case study, which is called Leveraging Digital Tools to Meet Pandemic Challenges. And with that, I'll end the webinar. We look forward to seeing you at our next HIS Talk webinar. Enjoy the rest of your day.
Thank you.
A pleasure. Thanks again for the time and the insights. Truly enjoyed it.
Talk to you later. Bye-bye.
Bye-bye.